A very good afternoon and welcome to the session on the topic the diabetes challenge in pregnancy and how do we fight it. We are glad to have Dr. Rajshri J. Shankar among us today to help us understand the topic. The doctor will help us through more in detail in the session today. So if you have any doubts, any queries, just stay tuned and post that on the comment section so that our doctor can take all your questions by the last. Also, the doctor is going to be sharing amazing details about these things. So just stay tuned. Also, you can ask the doctor about other doubts also related to the topic. So you can post it, and our doctor will be there to help you out. Doctor, you have the stage.
Thank you. Good afternoon, everyone. It gives me great pleasure to be here and speak on a topic that's actually very close to my heart. Um, the main reason being diabetes in pregnancy is a huge problem in our country. India is the diabetes capital of the world, and we actually have about 5 million women who are diagnosed with or who actually have gestational diabetes in pregnancy. So, this is a huge community problem, and I will tell you why managing this problem is so important because if we do this correctly, then we give good outcomes for both the mother and the baby. And this is not, we're not just talking of short term benefits, not just benefits that both the mother and child will have just in pregnancy, but we're also looking at long term health benefits that we can pass on both to the mother and the baby. So, this is something that we all should be looking very closely at, both from the medical side and from the public side. We should really be looking out for this problem. So, coming back to diabetes in pregnancy, this is called gestational diabetes. And gestational diabetes is diabetes that is first diagnosed in pregnancy. It doesn't mean that prior to pregnancy, there was no diabetes. It just means that we are discovering diabetes in that person for the first time. Now, in our country, there is a huge risk of having type 2 diabetes. Now, the main reason for this is basically that we are all genetically very prone to getting diabetes. Our parents having it, our grandparents having it. The genes are actually passed on to us, so we are at high risk of developing diabetes. Add to that, our poor lifestyle is definitely adding on to the problem in a huge way. Now, what has happened over the last 2, 3 decades basically is that our physical activity has come down significantly. Whatever we used to do physically, like walking, washing our own clothes, cleaning the house, everything has moved from manual to automatic, which means we don't really do so much physical activity at all through the day. In addition to this, the other big reason what has contributed to the epidemic of diabetes in our country is the huge change in the way we eat food. Uh, Previously, we had to cook food at home, it was home cooked food with not as much of sweets and sugars and artificial foods that we are now changing our diet too. I mean, partly this is because lifestyle has gotten faster. Everybody is out of the house. We want to eat things easily. We want more variety. The access to foods has actually changed significantly. So all this high calorie, high fat, high sugar food has definitely contributed to the diabetes epidemic in the country. So looking at this, this is therefore such a huge problem. And today I'm going to be concentrating on the effects that diabetes has in pregnancy, what effects it has on the mother, what effects it has on the baby. How do we go about diagnosing this problem? How do we go about then making the changes that the woman has to do to actually make the pregnancy healthier than what she started out as? What is the role for diet? What is the role for exercise? What is the role for medicines? So we are going to look at each one of these in quite some detail. So I hope you're all relaxed and you've had your lunch and you can sit and listen to this. I'll try not to make it a very long talk because what I want to do is pass on some important points so that you're not so that you can continue to listen to what I have to say. So first of all, why is it important that we need to know why somebody is diabetic in pregnancy? This is because of the huge complications or health issues that happens both to the woman and to the baby. For the woman itself, the consequences of diabetes in pregnancy is that she might end up having a higher risk of developing blood pressure issues in pregnancy. She is at higher risk of having a much bigger baby because of the uncontrolled sugar. And because of the big baby, she might end up having problems in labor, leading to higher risk of ending up with cesarean sections. Also, she is at very high risk of becoming diabetic later on after pregnancy. And of course, the complications of pregnancy, the damaging effect of high sugars on the heart, on the kidneys, on the eyes. So we are looking at all the possible complications that diabetes can cause that this woman will also be exposed to once diabetes is diagnosed or once she has diabetes. Now, what are the effects on the baby that we worry about? Now, if the baby is exposed to high sugars in the first part of pregnancy, there's a high risk of the baby born with fetal defects. That is possible. Um, there's also a higher risk of miscarriage when the woman has very high uncontrolled sugars in the first part of pregnancy. Now, going to the middle and later part of pregnancy, the risk of baby then having abnormal development, which we can sometimes pick up on the fifth month scan, and sometimes we might not be able to pick up on the fifth month scan. These abnormal defects can be caused by uncontrolled high sugars. Towards the later part of pregnancy, the risk on the baby is for the baby to be born much bigger. The risk after delivery is the risk of the baby having jaundice, the risk of the baby having low sugars after delivery. Now, these are all the complications that the baby gets exposed to because the mother has uncontrolled sugars. And the problem doesn't stop with that. It doesn't stop there. There is also a long term effect on the baby for having been exposed to high sugars in the mother's tummy. And the risks also are of of having obesity later in life for these babies, the risk of becoming diabetic themselves in the future, the risk of having heart disease in the future for these babies that were exposed to high sugars in the mother's womb. So now you understand why it is so important for us to actually diagnose this problem, because whatever we do in pregnancy has such positive effects both for the mother and for the baby. And not doing it actually means that we have missed this chance of creating a mother that's going to be healthy in the future, and we are actually producing a baby that is going to have all these health effects in the future. So that's why it's so important to concentrate on diagnosing this problem and managing this problem very well in pregnancy. Now, who are the people who are at risk of becoming diabetes in pregnancy? I would say I'm going to give you a list of what could make somebody more at risk of becoming diabetic, but the most important thing is to realize that um, all of us, anybody in the pregnant group can have a risk of becoming diabetic, especially in our population where there's such a high genetic risk of becoming diabetic. Anybody who is pregnant can become diabetic in pregnancy. But yes, there are certain factors that add on to that risk. For example, if somebody has a family history of diabetes, then that adds on to the risk. If the woman herself is overweight or obese, then definitely the risk of becoming diabetic goes up. If there is a history previously in pregnancy, in her previous pregnancy, that she was diabetic, then this pregnancy again she's at risk of becoming diabetic again. Again, if in the previous pregnancy, if she had a big baby, for example, the baby weighed more than 3.84 kgs, then she probably had some amount of diabetes in the past, but then she's at risk of again becoming diabetic this time. So these are all some things that we look out for when we try to identify who's at risk. But like I said in the beginning, all pregnant women are at risk of becoming diabetic. So then what does it translate to is that we need to identify diabetes in all our pregnant population. We can't just look at somebody's history and say, oh, this person is likely to become diabetic. Let us just test this person. That's not correct. We need to test all pregnant women at some point in the pregnancy to find out if their sugars are normal and to diagnose gestational diabetes. Now, there are lots of tests that are available and lot of cutoff values that are available from different societies that tells us this is the cutoff where we diagnose diabetes. The simple rule of thumb is if a fasting blood sugar is more than 95 and a 2-hour value is more than 130 or a 1 hour value is more than 130 and a 2-hour value is more than 120, then we should be thinking of suspecting or diagnosing gestational diabetes in that person. The best way, what we call the gold standard test, is to do something called a glucose tolerance test, where the woman comes in fasting. We take a fasting blood sugar, we give her a glucose drink which has a certain amount of glucose in it, and then do a test 1 hour and 2 hours later. This is the best method of diagnosing gestational diabetes. But there's a simple test where the woman can come in fasting as well, and then we give her the sugar drink to take, and then we test value 1 hour later. Now, based on that, we can then decide if a woman is not diabetic or if we are still suspecting that she could be diabetic, we could then do the glucose tolerance test. Now that we have diagnosed that the woman is diabetic, now we need to know how do we go about managing this. We do know that pregnancy. Why do women get gestational diabetes? Women who have had completely normal sugars before pregnancy can become diabetic in pregnancy, and the main reason for this is that the pregnancy hormones actually make the woman less responsive to the insulin that she actually produces. So she produces insulin, but the insulin doesn't work so well, which makes the sugars go up. Or she does not produce enough insulin also. It has a response to the pregnancy. There is some increased need for insulin, which also the body doesn't produce. So this is the reason why women are at more risk of becoming diabetic in pregnancy. And when you already have underlying diabetes or underlying pre-diabetes, then pushes women into diabetes in pregnancy too. Now, um, now that we have identified, now we've done the test, we have now identified that the woman has gestational diabetes. How do we go about managing this? I've already told you all the possible risks that all the possible problems or complications that can happen both to the mother and to the baby. So now that we have diagnosed this, now our main aim should be to try to reduce these complications. The first thing I spoke about was that if the baby is exposed to high sugars in the beginning of pregnancy, they are at high risk of the pregnancy is at risk of miscarriage and birth defects. So it becomes important, therefore, that we actually screen women before they actually become pregnant, which makes it a very important, which makes the role of pre-pregnancy counseling very, very important. So all women planning pregnancy ideally should see an obstetrician before they become pregnant, and then they can actually be screened for diabetes, because the advantage of doing that is if somebody already has underlying diabetes, we have missed this chance to set things right before they become pregnant, and so their risks and complications are already there when they actually start pregnancy, and we've missed the chance to correct it beforehand. The other advantage of diagnosing diabetes is that prior to pregnancy is that we have actually got a chance to enforce the healthy lifestyle habits that this woman can start to follow, so she can reduce the chance of actually becoming diabetic when she falls pregnant. And she also knows what to actually follow. That will actually mean that she would need lesser need for medicines or treatment in pregnancy, and she can manage most of her pregnancy with just diet and lifestyle changes. So the most important thing is all women planning pregnancy should basically go and see an obstetrician, do a pre-pregnancy check, identify if you're diabetic or not, and if you are, then start making those changes right from there on. So now that we have diagnosed diabetes in pregnancy or even beforehand, what are the changes that we can do to bring down the sugars? Now, there are three arms basically on how we can manage sugars. One is change in diet. Number two is change in exercise or lifestyle. Number three is medication. So we will come to medication at the very end. The first two actually play a big role in how we manage how we manage sugars, and this is something that all women should know on how to go about managing sugars in pregnancy. I even tell my patients right from when they get pregnant that we do not have to wait for their sugars to become abnormal and then start healthy diet and lifestyle. It's up to each one of us to actually make sure that we do not become diabetic. And whatever I'm saying now from a diet and exercise viewpoint can be followed by most women. So we do not have to become diabetic to follow these things. Now let's go on to what changes in diet are essential. Now, high sugars in the body is can happen easily when you take in foods that can break down easily and release sugars into the body. And things and foods that can do this are foods that are rich in sugar. So basically, when you take sweets, fruit juices, even canned fruit, anything that is very sweet releases sugar instantly and makes your blood sugar spike up and causes all the complications of high sugars in the body. Now, foods that don't break down easily. This is your protein that breaks down slowly in your body. You can have carbohydrate, which is complex carbohydrate, not your white rice. Think of brown rice, your millets like pargo, kambu. These are all the foods that actually break down slowly in your body. The advantage of these carbohydrates breaking down slowly is that they release sugar slowly into the bloodstream, so you don't have the spikes of sugar that actually cause the problem both in the mother and in the baby. So try. So how your food should be is eat um, 3 meals a day, but not big portions. 3 meals a day and two snacks in a day. This is a good way to basically spread out your meals all through the day. So you're not eating big meals that will cause a rapid rise in sugar and then a drop in your sugar. So see if you can spread out your meals through the day. So you're eating smaller portions when you're actually planning your diet right from breakfast. Breakfast is a very important meal, so that the importance of eating proper breakfast in diabetic women is that that is the time when your pregnancy hormones are at their highest. So they're actually spiking your sugars even when you are fasting. So what you should be eating in your breakfast is less carbohydrate. You should not be eating rice based foods at that point. You should always include some form of protein then. If you're non-vegetarian or even if you just eat eggs, eating two egg whites for your breakfast is a good protein basically to prevent your sugar from spiking further. So try to eat a complex carbohydrate. For example, if you're going to have dosa or idli, try to make it with millets. So one thing is it doesn't cause you a sugar spike right in the beginning of the day. Don't drink too much milk in the morning. See, milk itself is it's not a bad food, but it causes again it breaks down. It's liquid and it breaks down in your body very easily. So it causes spike in sugar. So you should be drinking small portions of milk. You can have a glass of milk, a small glass of milk. Do not add any additional sugar to it at all. Now, from now on, when you are diagnosed diabetic, you are basically going to cut out all sweets, anything that breaks down into sugar very easily into your body. So you're going to cut out any added sugar in any drinks at all. You're definitely not going to have fruit juices. You can have certain fruits, which is like apple and guava, and some berries, but try to avoid most sweet fruits. So we'll come back to breakfast. So breakfast, you're back to when we now that we're talking about breakfast, try to add more protein in your diet. You can even start off with some sprouts in your breakfast itself. You don't have to wait for lunch. You can have some sprouts for breakfast and have something like idli or dosa. Obviously, try to have something made with millets rather than white rice. So all this will make sure that you do not have a spike of sugar first thing in the morning. You can have a mid-morning snack, which is again you can have some buttermilk, or you can have green tea, and you can combine it with with a salad. What you can do, I mean, pregnant women do get hungry, so I understand that. But the important thing is that you choose what you eat, so that you are not eating snacks basically, like you can avoid all fried snacks. Don't eat a lot of fruit too, but you can definitely eat lots of green salad, which is basically your cucumber. You can add on tomato to it. You can add capsicum to it. Try to make a mixed salad and put some sprouts in it too. So and use this as a snack that you're going to fill up your tummy, but will also give you all your nutrition also while you're taking this. Again, your lunch should again have a certain amount of carbohydrate, which is like a cup of rice. If you can eat brown rice or millets, again, that could be a good source of complex carbohydrate. What we say, carbohydrate that breaks down slowly in your stomach. Combine it with definitely a protein on the side, which could be, if you're vegetarian, a bowl of dal, or if you're non-vegetarian, lean meat. Take like chicken or fish. Try not to have them fried. Eat steamed chicken and fish as much as possible, and use that as a protein. Have a big helping of green vegetables on the side. So your meal should basically include all these three varieties of food. So you should have your carbohydrate, you should have your protein, and of course you should have a big bowl of vegetable to go on the side. Again, you can have a light snack in the evening, and your evening meal also should be similar to what you eat for lunch. So this is basically how you're going to plan out your meal plan through the day. So basically, you're sticking to lesser carbohydrate, have a good amount of protein on the side, and have three portions, 3 to 4 portions of salads a day. Now that will keep you not being hungry, and it will also help to maintain your sugars. The other advantage of eating a lot of green vegetables, basically, vegetables have a lot of healthy nutrition in it. They have a lot of vitamins and minerals that are essential for the baby's growth and development, and also to protect you from falling ill with colds and infections. Now, the other benefit of eating vegetables is that they have a lot of fiber in them. Now, there are two types of fiber. There's soluble fiber, there's insoluble fiber. The benefit of soluble fiber is it makes you absorb fat slowly from your intestine. So it has a good role to play. It has a role to play in controlling the amount of fat that is absorbed into the body. Then you also have the insoluble fiber, the fiber that doesn't get absorbed, that will help the motions to be passed easily. Pregnant women are prone to constipation, so eating a lot of green vegetables helps to prevent this problem in these women. So this is a diet plan that you can follow. I would definitely suggest that you also see a dietitian and make a diet plan that works specifically for you, because I understand that everybody's diet is different. So depending on where you stay, you can actually see your dietitian locally and make a diet plan. For people who cannot access a dietitian, there is plenty of information available on the net which you can access and see what diet plan works for you. But I would definitely say sit and make a diet plan so you actually know what to eat, what not to eat, what to eat with your local resources. Because whatever I say, finally has to be something that is available locally for you. So look at what your local resources are and work with what is available and work with what you normally eat. And don't go try changing, seeing on the net, don't change to fancy foods. Try to incorporate this in the diet that you would normally eat every day, but follow the general guidelines that I have mentioned as to how much carbohydrate, what type of carbohydrate, what type of foods you're eating. Just focus on those and try to tweak your diet accordingly. Okay, so this is the importance of diet that you would need to follow, and diet plays a very important role in managing sugars. Whether you're pregnant or whether you're not pregnant, it plays a very important role in how you're going to manage your diabetes. The next important form of treatment for gestational diabetes is exercise. Now, there are two ways you can do this. Increasing physical activity definitely helps to control sugars. With and if you combine it with dietary changes, it definitely helps in reducing sugars. What we know is that even a 10 to 15-minute physical activity straight after your main meals helps in controlling the sugar spike that will happen after you eat. So a 10 to 15-minute walk after breakfast, after lunch, after dinner is a good way of controlling the sugars that will happen, that will start to rise once you have had something to eat. So this is something that you can follow on a regular basis. So after every meal, have a 10 to 15-minute walk. If you're not able to do that, try to do a walk in the morning, try to do one more walk in the evening. 20-30 minute walk, 20-30 minute walk in the evening too. This is another way of doing it. But see if you can incorporate these walks after every meal, which will definitely help in controlling the sugars. So we have talked about two main forms of treatment. And of course, definitely we come to the third part, which is what your doctor will talk to you about, which is starting medication for diabetes. Now, medication for diabetes can be in the form of tablets, and it can also be in the form of insulin. Now, when you're not pregnant, most diabetes can be managed with tablets itself. But the difference in how we manage diabetes in pregnancy is that we actually start insulin very, very early. The main reason being the type of control of sugar that we need in pregnancy to prevent the side effects of the high sugars. That tight control usually can be provided mainly by insulin. So if somebody's sugars is not being controlled by diet and exercise and with tablets, we will move on to insulin quite early on in the treatment because we do not have a lot of time to waste in pregnancy. When you're not pregnant, we can try all these initial treatments to see if the pregnancy, to see if the sugar comes under control, and then move on to insulin later on. But in pregnancy, this will be started earlier. Again, the common misconception that a lot of people have is that taking these medicines for diabetes affects the baby in some way. Actually, that's not true. These medicines or treatments for pregnancy, for diabetes and pregnancy have been used for a long, long time. It's been used for many decades, and the side effects of these treatments on the baby is you do not have to worry about it. But not taking the medicines and allowing the sugars to be high has a higher has more harmful effects on the pregnancy and on the baby. So if medicines are necessary, do take it. Do not deny taking the medication because you're worried about the effect of the medicines on the baby. That is not that is that that harmful effect is not there. The harmful effect comes from the sugar itself and not from the medicines. So your doctor, once you're diagnosed with diabetes in pregnancy, your doctor will need to see you at more regular intervals. Um, most clinics now also have a diabetologist who will also be keeping a close eye on the mother's sugars and monitor and decide on changes in the treatment that will be required. What we do know is as the pregnancy gets more advanced, as the baby gets bigger, the sugars will tend to spike more. And so, at every point, what treatment we would need to start off with and what treatment that somebody will need as the pregnancy advances will keep changing. So, it's not just diagnosing it, we will continue to closely monitor the sugars all the way through pregnancy. And this will include regular testing at home and also some tests done in the lab also so that we do not missing out, so we do not miss picking up changes in the sugars as the pregnancy gets more advanced. So once we have controlled the sugars very well in pregnancy, we then have to also monitor the effect of the sugars on the baby. Now, one way to monitor the baby is to do regular growth scans. So even sometimes when we see that the sugars are well controlled, when we see that the baby's growth has not has not followed a normal pattern and the baby's growth is accelerating, baby is growing much bigger than what we anticipate for that period of pregnancy, that also gives us an idea that something is not right, even if the blood tests look normal. Maybe we need to look at how the blood tests were done. That also gives us an idea that the sugar is not very well controlled. So we would do regular growth scans on the baby to monitor the effect of sugar on the baby's growth. So you will need regular growth scans, which we would generally start from about 26 to 28 weeks and do it every month to monitor the progress of the baby's growth and development. So, also babies who are exposed to high sugars in early pregnancy, they would need a detailed scan to look for certain birth defects at 5 months, and also because of the risk of these babies having a higher risk of heart issues, they will also be needing a detailed check of the heart, which we would usually do between 23 and 24 weeks. So from the baby side, more frequent monitoring of the initially doing more detailed scans to rule out abnormalities will be done. And then from 26 to 28 weeks, there will be regular growth scans on the baby to monitor the baby's growth and development. Now that we have monitored the pregnancy both from the mother's side and from the baby side, once everything is under very good control, these pregnancy, if we are able to manage diabetes in pregnancy very well, then the risk of complications both to the mother and to the baby can be significantly reduced, so that the outcomes for the pregnancy are very similar to somebody who's not diabetic. So it's very, very important that we identify this problem, do all the right things, which means both the woman and the doctor work together to maintain the sugars as near to normal as possible to reduce the effects on the mother and the baby. If we manage to do that through the pregnancy, then we have managed the problem very well. Then the outcomes are very, very similar to somebody who's not pregnant. Sorry, somebody who is not diabetic, and that is the basic aim of managing sugars. That we give the woman a good outcome. We help the baby to be normal, so baby doesn't suffer with any complications just after delivery, and also the long-term outcome of these pregnancies. We can reduce the complications of high sugars that the babies can get exposed to if we do not treat this properly. So it is a combined effort that has to happen between the obstetrician, the diabetologist, the dietitian, and of course the mother. This is a combined effort that is necessary to give the best possible outcome to the mother and the baby. Now, now that we have come to the delivery part, um, once somebody has been diagnosed as diabetic in pregnancy, once the sugars have been very well controlled, then normally we would plan delivery at about 38 weeks. And this is mainly because once treatment for sugars is given, then there is some risk that prolonging the pregnancy afterwards, once we know the baby is mature, can have some risk to the baby. Now, diabetic pregnancies, especially if they have been very poorly controlled, there is a risk that the baby might have stillbirth. So now, once we know that the baby is mature, once they that which is when the pregnancy has reached 38 weeks, the general plan would be to induce labor at that point in time, if this is somebody's first pregnancy, or basically to plan delivery at about 38 weeks. If this is somebody's first pregnancy, or they have had a history of normal delivery previously, then the plan will be to induce labor. If somebody has had a cesarean section in the past, then there needs to be a discussion as to whether to plan a repeat cesarean section, or if they are very favorable for induction, then plan induction at that point in time. That would need specific counseling depending on what has happened in the past. So the plan would be to deliver at about 38 weeks. Once the mother is delivered, then once the baby is delivered, the pediatrician will obviously be monitoring for signs of low sugar in the baby after delivery, and also risk of jaundice after delivery. Now, all the risk of all this should be much, much, much lesser if we have controlled the sugars very well in pregnancy. So, babies who have not been exposed to high sugars, then the risk of both these complications should be very, very less. Now, our management does not stop here. What happens post delivery is that the sugars for the mother will come back to normal because the pregnancy hormones are now removed. The sugars will settle to normal straight after delivery. But what we have seen in our population is even 3, 4, 6, 8 weeks post delivery, sugars tend to start to rise. A small proportion of women will continue to show sugars, high sugars, about even 6 weeks post delivery. So the problem doesn't stop there. We do know that women who become diabetic in pregnancy for the first time, their chance of becoming diabetic in the next 6 to 10 years is more than 50%. That means half of these women are going to become diabetic in the future if they don't continue to follow a healthy lifestyle and maintain a proper diet. So the risk is as high as that. So the problem doesn't stop just after delivery. We have to look at the long term problems that these women might have if they do not follow the same diet and lifestyle plan that they started in pregnancy. So the way to manage these women would be to do another detailed sugar test 6 weeks post delivery. One, to identify if some of these women are still diabetic and then start treatment for them. For women whose sugars go back to normal post delivery, they should be warned that if they do not follow a good lifestyle, then they're likely to become diabetic in the next few years. So it's very important that they are counseled adequately, that they follow a good lifestyle pattern and they get their sugars checked on a regular basis. So I hope this has given you a good overview of how important it is that we manage this common health problem. Now, India is going to have 5 million women every year diagnosed with gestational diabetes. So it's a huge challenge that this community is going to face. Because one, we are going to have affected women who will have complications later on, and number two, we are creating children who are basically going to have high risk of complications later on in life if we do not manage this problem in the proper way in pregnancy. So it's imperative for all of us, I mean, as medical professionals ourselves and as the general public, to be aware of this problem and to follow the guidelines as well as we can to reduce the damaging effect of diabetes that we are continuing to see in our country. I hope this was informative. Um, Thank you.